Good afternoon. I'm Alison Dundes Renteln. I'm a professor in the Department of Political Science and International Relations. I'm delighted to welcome you to this panel today, Post-COVID, the Unequal State of Health in America. This is part of our Dornsife Human Rights Initiative. International law guarantees the right to the highest attainable standard of health. And of course, the ability to exercise other human rights depends on a good standard of health. And the pandemic, I think, raised awareness of the extraordinary importance of health and human rights. So that's why we gathered here today to discuss the lessons learned and how we can respond more effectively in the future. We're also here because universities have a duty to promote and protect human rights. This event was organized by our wonderful USC Center for the Political Future. And we would like to thank the directors of the Center for the Political Future, Bob Shrum and Michael Murphy, as well as Kami Akaban and Nicole Amaleo for taking the lead on today's program. We'd also like to express our gratitude to all the co-sponsors, and we're very happy to have our colleagues and friends with us today. Paul Newton from engineering, Lee Turner, who is a colleague from UC Irvine, heading a healthcare ethics center and a USC alum of social ethics. And we have some Brazilian visitors, Dr. Domingues and Ms. Fernandez. Now I have the privilege of introducing our fantastic colleague, Bob Shrum, educated at Loyola High School, Georgetown, and Harvard Law School. He is a brilliant political analyst. He has been described as the most sought-after consultant in the Democratic Party. He's a legendary political consultant. And he came to USC after teaching at the NYU Wagner School of Public Service, and he's had a very distinguished career as a political consultant. He's worked with a lot of the major candidates, Edward Kennedy, Al Gore, John Kerry, just to mention a few. His book, No Excuse, Concessions of a Serial Campaigner, was a national bestseller, and he earned a Lifetime Achievement Award from the American Association of Political Consultants and was inducted into its Hall of Fame. Currently, he's the director of the Center for the Political Future, as I mentioned, and holds the Carmen and Lewis Warshaw Chair in Practical Politics. He teaches popular courses that receive rave reviews, and he's been very successful in helping build community here at USC by encouraging people from different political perspectives to come together to solve problems. We worked together on a conference on tribalism some time ago. And so I must say it is really an honor and a pleasure to be his colleague. I always enjoy our collaborations. Now let me turn the program over to Bob, our beloved Bob, to introduce our awesome panelists.
Thank you, Alison. By the way, I have to say, I would have preferred a half a Lifetime Achievement Award from the Association of Political Consultants. I can't say enough about Alison. She's committed, she's visionary, she has really put her heart and soul into getting this kind of event done here on campus, and it does implicate so much of American politics. So I have to thank her. I have to thank Kami Akaban, our executive director, and our incredible staff. We're partnering today with, and this is a long list, so I'll do it fast, the USC Dornsife Center for International Studies, the Departments of Anthropology, Gender and Sexuality Studies, Political Science, International Relations, Sociology, along with the Institute for Inequalities and Global Health, the Institute for Equity Research. You can see Alison has been very busy on this. Keck School of Medicine, Narrative Medicine, the Price School of Public Policy, the Levan Institute for Humanities, the Blackstonians, and the Institute for Advanced Catholic Studies at USC. We're going to have a conversation for about 40 minutes and then open this up for questions from our audience. We have a terrific panel with us today, even though Congresswoman Nanette Barragan couldn't be here because of the chaos or the clown show in the House of Representatives yesterday. But I'm very pleased to introduce the guests who are with us. Sofia Gruskin is the director of the USC Institute on Inequalities and Global Health and holds posts at Gould, Keck, and USC Dornsife. You must be tired. She serves on numerous international boards and committees, including the PEPFAR Scientific Advisory Board. That's the initiative that George Bush started in Africa and that has vaccinated or dealt with HIV for so many millions of people there, and which is under the gun right now. And the Lancet Commission on Gender and Global Health. Suji Rao served as senior policy advisor on the Biden White House's COVID-19 response team. He is now the director of the Public Exchange Health and Wellbeing Practice at USC Dornsife. Dr. Bradley Stoner is the head of the Department of Public Health Sciences at Queen's University and the former president of the American Sexually Transmitted Diseases Association. His research also analyzes the political and economic underpinnings of health and wellness and disparities in healthcare and health access. So I'm just going to throw out a question, then we'll just go down this way and we can have a conversation. I have a bunch of questions, but if the conversation goes in different directions, that's fine too. What was the #1 lesson we learned about our healthcare system from the pandemic?
Do I get to go first?
You do.
All right, I'll take it. Okay. That we weren't prepared, that our systems are not well integrated, that those who lost the most are those who are the poorest and the most vulnerable. And frankly, it's a lesson we shouldn't have to keep relearning.
Sujini?
It's hard to limit it to just one, but I think one that I think kept coming up over and over and over the more that I think about it is that given our healthcare system, given how decentralized it is, there's a lot of positives that come from that in terms of innovation, R&D, experimentation, different models. But one of the biggest negatives is that emergency response and national coordination is really, really difficult when things are so decentralized and so federated and so atomized. Getting everyone to sing the same tune, getting everyone to work from the same plan, setting one plan that works for everybody is exceedingly difficult given our situation, and that's something that just presented itself over and over.
Bradley?
For me, the COVID crisis wasn't as much a healthcare issue early on because it wasn't anything to do with healthcare other than hospitalized. It was really a health issue. And so I think the #1 lesson we learned is how COVID unmasked and magnified disparities that already existed in society. For example, stay-at-home orders were accessible for people who had jobs that would allow them to stay at home, but some people who had to work for a living still had to go in, put them at greater risk for exposure, and healthcare outcomes were clearly worse for disadvantaged communities.
Okay, let me do a follow-up to that. How did we handle this pandemic relative to other countries, and what were the strengths and weaknesses that we saw in our response? You could start down there.
Oh, where do we start? I think, to me, the issue was that the science base was evolving, and I don't think we communicated that very well early on, that we really didn't know what to expect. We had models. We had the original SARS outbreak in the early 2000s, and I think a lot of us thought, myself included, that it would be a quick epidemic that would clear and then we'd get back to normal. So I think we didn't have models for how to deal with it, and I don't think we communicated very well that the knowledge base was going to change because new information was coming in, new models were being developed. So I think we could have done that a little bit better. I'm not sure other countries handled it that much better. I think we were all in a sort of a global gray zone.
I'll pick up on that and say a couple things. On the communication front, I think if you all remember when you're a kid, you play the game of the telephone, right? Where you're all like sitting in a circle, you whisper something in your ear and it goes all the way down, and by the time it comes out next to you, the message is completely gobbled and totally different. I think given what I mentioned earlier about the decentralized nature of our healthcare system, a corollary to that is that it takes a long time for new science, new learnings, or just new practices to sort of wind their way and disseminate their way all the way down to a doctor's office or a community clinic to where it actually meets real people where they are. And so as a result, when science is changing, when what we're learning is changing, when the effectiveness of certain treatments, which is something I know a lot about, changed, it was really difficult to sort of disseminate that information down to the ground quickly, given just the entire stress that everyone was under, the conflicting pieces of information, and then you layer on top of that all the polarization that was happening that made certain messages not resonate, which we'll talk about in a minute. The other thing I want to say about how we sort of fared is, I think our healthcare system fared better than our social fabric did. There were a lot of situations in particular states or cities where the healthcare system bent, frayed, even broke for a little bit here and there. But for the most part, we did not have widespread collapse along the lines of what some other countries saw, certainly during the Delta and Omicron era as well. And there are a lot of reasons why that I think that is the case, but that was one thing that I sort of observed. I think one of the weaknesses that it revealed, though, is that our pipeline of healthcare workers in this nation is extremely fragile. and frayed. And if you've spoken to any clinician or healthcare worker over the past few years, they're likely burned out. They're likely thinking about leaving the profession. They're also not likely to tell someone to join the profession if they're considering it, which I think are tragedies as the son of a whole family of healthcare workers. And so I think that's one weakness that was sort of revealed, is just how fragile, even though we have a world-class system when it comes to healthcare workers in this country, it's fragile. And I think the long-term outlook for it is scary when you think about we need to really drastically increase the number of trained and supported healthcare workers we have.
So specifically to you came in, I presume, in January of 21 with the Biden administration. And we had the vaccine. We'd had it for a little over a month. It was accessible to people. Were we ready to distribute it? What did you have to do to get it out there?
The short answer was no. The government was not fully ready to distribute it and meet people where they were. What people say, and what I've said before, is that vaccines does not equal vaccinations. You actually need a distribution plan of how you're going to get product out into the field, how you're going to make it easy, how you're going to leverage partnerships and community clinics and pharmacies and all of the sort of different nodes in our distributed healthcare system. How are you going to leverage those to make it super quick and easy and convenient and free for people to get access to a vaccine? And at the beginning of the Biden administration, there wasn't a clear vaccination plan, and so the team that I joined created one and rolled it out. When the president first took office, President Biden, he said, we're going to have 100 million shots in 100 days, and everybody thought he was crazy. And it turns out we did more than 200 million shots in 100 days. And that was because of deliberate planning and really.
But you had to create a plan from scratch. From
yes, essentially, yeah.
So we had a vaccine suddenly, or we had several vaccines, but no plan about how to get them out there.
I mean, certainly not a way to get it out quickly, robustly, and certainly not with equity at the heart of it. I think one of the things that you mentioned, Sofia, is just how the pandemic revealed how the people that faced the most challenges in every aspect of life were bearing the brunt of this pandemic in so many ways. And so one of the things that we kept at the center of every strategy was we would say equity is at the heart of what we do. Now, those are just words unless you actually put them into action. And so one way that you put them into action is how can we leverage partners and nodes and places in the field that are already providing services, that are already known to people that face the biggest challenges or at the most risk, and how can we leverage those partners? And then, by the way, how do we get them vaccines so that they are ready early on to have large quantities of product to get into people's arms? And then how do we think about different unconventional partnerships? We worked with sports leagues, we worked with companies, we worked with mayors and governors and people all across the political spectrum and across the private sector as well, to sort of really try to create this moment of everybody, all hands on deck. What can you do to make your community more likely to get vaccinated?
Sofia?
I want to go back to kind of our space in the global space more generally. And I would say that one of the things that was really difficult is that we showed a real lack of interest in global solidarity and in global action. Remember at that time, the US was threatening to pull out of WHO. And remember at that time that there was fragmentation happening within our country in a way that had not happened before in terms of public health in quite the same way. Now, one of the things I wanted to kind of pull out in terms of just being able to think about how it is that no country can do it alone. And I think there was really a sense within the US as though we could do it alone or could not do it alone. The new White House national security strategy, I wrote this down because I thought it was important, because I thought it was a real response to kind of what happened, which is we recognize that we must engage with all countries on global public health, including those with whom we disagree, because pandemics know no borders. And I actually think that that's key. And I think many of the things that we need to address pandemics, surveillance, finances, dealing with intellectual property, development or distribution of vaccines, all of that requires coordinated global political leadership. And there's a critically important role for the US to play in the global space. And when the US is not playing that role, then it has real implications for what happens across the globe. And I feel like we were really a weak link at the global level.
Yeah, can we, several of you alluded to this, but can we talk about the impact of political polarization on the pandemic and what that means? I mean, when I was in grammar school, They lined us up one day, said, line up against the wall, you're all getting the polio vaccine. I mean, they didn't send notes home to our parents or anything like that. I mean, I was in a Catholic grammar school, and if you'd refused to get vaccinated, you wouldn't have been in the school anymore. We all got the vaccine. Are you surprised by the volume and intensity and political resistance from people who have opposed vaccines and earlier on resisted lockdowns? I mean, anybody can start.
Go for it.
Well, as a public health professional, yeah, I was very surprised at the politicization of science and the idea that science should be an apolitical tool, used correctly. It simply gives you information. I think it can be open to interpretation, but I think that was new to me, this idea that there can be alternative facts or alternative interpretations of data. Now, science is evolving, and I go back to my communication concern that I think that initially it was like masks work. And then we find out, well, maybe they don't work as well as we thought we did. And so I think the communicating the fact that these databases change as new information comes in could have been done better. But that was so politicized, and the vaccine resistance that came out of that. Because I remember those days, Bob, where people weren't resistant to vaccine, it's just they didn't have access to it. And our job as public health professionals was to increase access. But now you had people actually pushing back and saying, no, I don't want that. And that was new.
Yeah, I think when I think about the impact of polarization, it was devastating and it was deadly. I saw this firsthand. So one of my jobs on the COVID team was to coordinate what we called the federal surge response effort, which was working with governors or other jurisdictional leaders, territories, in some cases cities, whose healthcare systems were either fraying or at risk of being overwhelmed. The federal government had a host of resources that we could provide to help, everything from personnel in some cases, whether they're from HHS teams that are kind of activated across the country. In many cases, we deployed active duty military personnel who were trained because, as I mentioned earlier, there's no cadre of trained healthcare workers just like twiddling their thumbs ready to be called up in this country. Like everybody was working in their communities. So the only place to get extra personnel in many cases was the military. But what was, and as well as tons of reimbursement through FEMA and all kinds of other federal coordination to get tests and masks and whatever was needed. But the linchpin of that is that the governor had to ask. You have to ask the federal government for help. And early on in the pandemic, especially during the Delta wave, but also during the Omicron wave, there were states that, based on the data, we knew they needed help. And we would call them on the phone every single day. My job, before I was coordinating the whole effort, I was in charge of the Southeast and Texas.
Lucky you.
So I was on the phone very often or through email with the governor's team in Florida, and they just didn't want our help. They just did not want our help. Now, did they need it? I would say yes. And to this day, there was an article in the New York Times a couple months ago about this, about sort of like the cost in lives and suffering in Florida because of the sort of choices that they made and how they wanted to respond. And it was really, really hard. Those were dark, dark days that I would come home and just sort of be like, what are we doing? Like, these are public servants. You're supposed to be protecting the people you serve, and it just wasn't happening.
Yeah, can I add? Can I just jump on
Yes.
that? Which is, I mean, the fragmentation by state, depending on kind of the attitudes. And I mean, I again want to just say two things. There were 46 states that introduced bills to try to limit governors or health officials' authority, right, in terms of what they could do during pandemics or other emergencies during that. That is shocking to me. I don't know. I mean, I just find that crazy. I mean, I don't think it passed in more than 11 states, but it's the attitude that really worries me. And this idea, mistakes were made, sure. But it's the implication of this attitude and basically how this is going to limit the ability of public health officials in the future to be able to take the actions that are necessary to mitigate crises. That's what really worries me.
I find it fascinating. I mean, Travis Kelce and Taylor Swift are getting attacked, not only because they're an item, but because they're going out and encouraging people to get vaccinated.
Yeah, totally.
How do we do anything about this? I mean, are we stuck with this permanently? I read an article that was stunning. Nate Silver did this analysis of what happened in red states versus blue states. And in red states, there's no difference between the death rates and the illness rates before the vaccine. after the vaccine, there are decided differences, and he asked the question, why are some of the red states killing off red state voters? What are we going to do about this? Anybody?
I'll start.
It's an impossible question. But
It is an impossible, I was just going to say, it's an impossible question. Okay. One of the things, I want to think about trust for a moment and what it means to take people where they are and what it means to be able to take the time to recognize and engage with people one-on-one to deal with their concerns. That is incredibly, if I can say, expensive, right? It's very time-consuming to be able to do that, and yet it's critical to how we have to think about what is public health going to look like in the future. Heidi Larson, who is, I don't know if people know her work, but she really is kind of the leading expert on vaccine hesitancy. And she started doing work in polio. It didn't start initially around COVID, but she says that basically you have to get to people's emotions. You have to think about beliefs, feelings, why people trust and don't trust, and you really have to be able to get into that space. And like I say, that may reframe how we think about what public health is and what prevention looks like.
If I'd add two things to that. I think that's really nice, nicely put. I think building trust in a crisis is impossible, right? Like trust needs to be built ahead of the crisis so that when something happens, people rely on you and they know that you are a source of help or support or whatever it may be. And so I think that means the time to build trust in some of these communities and across lines is now, when we're not necessarily facing so much of an acute crisis on the public health side, at least that we know of. The second thing I'll say related to what you said is, we were always looking, when it came to like vaccine hesitancy and coordinating the national campaign that we had, that We Can Do This campaign, we were always looking for like, what's the right message, right? What's the magic words that we can say that will sort of cut through the noise or cut across political lines or cause people to put that aside and start to look at this question in a different way? And the answer was there was no magic words. What was way more important than the message was the messenger. And so the most effective, the most persuasive conversation is one that happens oftentimes in real life, not online, between people that already know and trust each other. So that was our strategy. We thought about it in terms of operationalizing that, was inspiring, equipping, and empowering local community leaders to go out and do that work wherever they were, whether it was churches, communities, neighborhoods, whatever it may be. That's really hard to scale. But you have to start now, and you have to keep doing it over and over and over, so that when you need that bank of trust to deposit or to pull from, you actually have some in the bank.
Well, that's absolutely true, Sujit, but leadership comes from the top, and we actually had a leadership that was, creating chaos by,
sure.
taking settled positions. Bob, you're talking about vaccination. I mean, these were settled. I never thought I'd see a day where vaccines were considered to be an option. And now we've got people. And Sofia, when you said vaccine hesitancy, we actually had rhetoric that was leading people, not hesitancy, but actually refusal. Yeah, it's not like they're all wavering, but they're actually refusing the vaccine, and that was new. So the stark polarization about individual autonomy versus the greater public good, that's the kind of argument that blew up, I think.
I'm going to get to the inequities in a moment, both internationally and here in our own country. But first I need to ask this, since we've been talking about the pandemic a lot. A lot of Americans, in fact, probably a majority of Americans, vast majority, are acting like the COVID pandemic is over. And yet we see cases again on the rise. And I guess for a lot of people, this new vaccine shot, if I'm like me, you're not on Medicare, one of the only benefits of being older, they have to pay for the vaccine. So is the danger over, and what are our healthcare systems not doing that they should be doing?
Well, I went first last time. Go for it.
Oh.
Go for it. It's your turn.
I would say the era when COVID is sort of such a dominant force in our lives that drives our behavior day to day, I think I've been humbled by this virus many, many times, so I should be careful, but I think that era is behind us. And the reason why is I think we do now have a wide variety of really effective tools, whether it's vaccines, whether it's antiviral treatments, whether it's antibody treatments in some cases, although some of those are less effective against current variants. But we have a lot of tools, and we have now 3.5 years of experience in terms of living with it and understanding how to kind of make our decisions at a micro and macro level to make use of those tools. So I do think the era of, what it felt like in 2020 and 2021, I think that era is behind us. But the new era is almost more challenging in some ways, in the sense that people need to be much more mindful of their personal circumstances more, I think. Then there's sort of no longer kind of one-size-fits-all approaches that make sense. So I kind of personally, I think of it almost like the weather, where I am mindful of what COVID levels are like, and I let that guide my decisions about what kinds of activities I'm doing or whether I'm wearing a mask in a certain place or something like that. In terms of vaccines, I think of it like the flu now, where every fall or right before the respiratory virus season, I will get a booster shot. I think, the CDC and the FDA have done a really good job this year of calibrating the vaccine that's approved this year to be responsive to the variants that are circulating. And I think that knowledge will only continue to get better and better. So I think that is the bright side that I look at going forward.
That is a very glass half full approach.
Yeah.
The glass half empty statement is that COVID test positivity right now stands at 13.8%. And as a public health physician, I can tell you anything above 5% is considered to be a concern. 13.8%, and it's going up. COVID hospitalizations last week alone increased 2.7%. I think COVID is still here.
Oh, yeah.
Now, is it the same disease we had in 2020? Probably not.
Probably not. And I think it's likely to be here, unfortunately, just given how infectious it is. I think it's very difficult to kind of eradicate it. But to the question of how do we manage it, how do we prevent the most vulnerable people from being facing unnecessary risk? How do we prevent our hospitals from getting overwhelmed? I think those kinds of questions are ones that we really need to focus on now.
Especially in states where people are not getting vaccinated.
Yeah.
And are people getting vaccinated?
Numbers are really down.
They're low now.
They're pretty down.
It's continuing to happen for sure. I mean, I think even now, those who face those who are most vulnerable due to advanced age or health risks are the ones that should be prioritizing getting it. And I think there's still disproportionately more of them getting shots, but it obviously is way less than it was a couple years ago.
I have a friend who lives in Louisiana, teaches there, and his LSU will not cover, their health plan will not cover the cost of vaccination. And he said there are lots of people on the staff, he went and got it, but there are lots of people on the staff who say, I can't spend $60 on this.
Yeah. No, this is a huge consequence of the public health emergencies ending and, the lack of Congress providing any funding for ongoing pandemic response, including preparing for future ones, is that we're sort of reverting back to our default system, our default healthcare system in this country, which, as we know, is extremely inequitable. And as I mentioned earlier, is extremely sort of diffuse and decentralized, which just means that the people who face the greatest challenges are going to continue to have the highest barriers in getting care, unfortunately.
So let's talk about, since we're kind of in a slightly depressed mood here, let's talk about the inequities. And I really want to focus on two. First of all, if you look at vaccination rates in a place like Africa, and you look at the record of the leading countries, the leading economies, hoarding vaccines to the point where some of them spoiled, not even sending them to places like that.
That's right.
How are we going to deal with that? And then, related to that, how about the barriers that marginalized and underserved groups faced in this country during the pandemic and the lasting effect on communities of color and low-income groups? How are we going to redress both these problems? Another hard question.
Yeah.
I'm going to not answer your question. Okay, let me give it a shot. All right. So, I think the first thing that I think is really important to talk about this country first is that we have to fight the narrative that these things all surfaced during the pandemic. They've all been here. This has been the reality. And so we need to be able to address the fact that this has been the reality. That's important in terms of trusting the communities who's most affected. It's also about how we can be most useful. There was this study in the Lancet last week that showed that when it comes to mortality in the United States, the gross inequalities amongst racial ethnic groups is the norm. It's not the exception. And that was the case for a study that was done between 2000 and 2019, so before the pandemic. And now it's mortality data, but I think that the implications of it are really obvious. And we really need to be thinking about what it is about this deepening of divisions between the haves and the have-nots. And I come back to the fact that there's growing differences, not in terms of how it is that the pandemic impacts our lives, not just based on race and class, but based on what state we live in. And I'm going to keep coming back to the states, your friend in Louisiana, right? The differences in terms of how states are dealing is really, really important. We are so lucky to be having this conversation in California. I cannot say that enough. Go ahead, yeah.
Well, I'll just jump in, and you're absolutely right, Sophia, and it's not a small difference. Between March of 2020 and June of 2021, Latino and Black persons with COVID-19 were 2.8 times more likely to be hospitalized and 2.1 times more likely to die from COVID than non-Hispanic white persons. 2 or 3 time difference. So I think that those disparities are really profound. It's really important to address that.
I think on the global disparity side, I'm personally very proud of the fact that the Biden administration was kind of a pioneer in distributing and donating vaccines abroad. We committed to donating more than 1 billion doses. I think they've delivered more than half that already. And these were mostly to countries that were extremely populous countries that needed help getting more vaccine. Nigeria, Vietnam, Indonesia, Pakistan, Bangladesh, for example. And what we realized is, just like I was mentioning earlier, how vaccines does not equal vaccinations, donations does not equal vaccinations. The sort of last mile distribution challenges across the world were very difficult. Cold chain storage, using different types of vaccine that had different temperature storage requirements, and getting those out into the field, especially in remote locations across the world, was a logistical challenge that my colleagues were wizards at navigating. But it goes to show you just how big of a challenge it is to address these kinds of inequities. It's necessary work, it's important work, but it is always a challenge to get sort of that last mile, especially when you're talking about globally.
Can I put a little unhappy spin on that for a moment,
Sure.
if I may? Which is that, yes, the United States, we did distribute, and we were starting to have that conversation kind of over there. But we donated first to countries that were our strategic partners. We didn't donate first to the countries necessarily that were most in need, from my perspective. And I think that we have to recognize the way that politics plays into the ways in which even distribution was taking place.
Well, and even before that, in terms of vaccine nationalism, wealthy countries made pre-orders for vaccine even before the vaccine was available. So the 32 richest countries in the world, accounting for less than 13% of the world's population, had pre-ordered half of the vaccine that was going to be produced by Pfizer, Moderna, and AstraZeneca. So the greatest number of vaccines, and I live in Canada now, Canada had pre-ordered enough doses to cover its population 9 times over. So there was plenty of vaccine.
What happened with that extra vaccine?
So that's supposed to go to COVAX, which is the global vaccine distribution system. But why did wealthy countries have the need to lock into vaccine pre-orders so quickly? And it speaks to, well, we'll get everybody vaccinated here first. And you can understand the sentiment behind that. But in terms of global health equity, that kind of contributed to it.
Yeah, I think people were so terrified. I mean, and if you were older, you were locked in your house or your apartment for a year and a half, and when the vaccine came, and by the way, I was commenting before the panel, we talk about Operation Warp Speed, as if this thing came out of nowhere in 11 months. If you looked at the people who won the Nobel Prize in Medicine the other day, it turned out they had been fighting for years to use mRNA technology, and what happened was, when the pandemic hit, Pfizer and Biogen and Moderna went to them and said, we want to try your technology. We think this might work. So I think people were terrified.
They were.
And I'm not sure that you can actually, in a similar situation, overcome this. I'm not, if you went and said in America as a political leader, if you said, by the way, Iran really needs a lot of vaccines, so we're going to ship a lot of vaccines to Iran. I'm not sure that that's politically viable.
I'm not sure they would say yes either. I mean, if you think of the challenge I was talking about earlier, that was a factor on the global stage as well. Oftentimes, where the need was not where the appetite to cooperate was. And that was tough.
Or China has its own vaccine, which we don't know anything about.
And they didn't have mRNA vaccine for a long time.
Right.
And we knew that wasn't effective.
Right.
So that we knew that they were facing challenges, but of course there's barriers for their ability to cooperate.
Yeah, I want to give, did you want to add anything?
No, I'll wait, go ahead.
No, I just want to ask a kind of wrap-up question from me and then turn this over to the audience. What do we have to do to make our healthcare system more equitable? Not just in a pandemic, but in general, because as the statistics, Sofia, that you were talking about pre-pandemic indicate, there are incredible disparities. What do we do?
Well, I actually want to go back
Please
to
do.
the global if I can, because
Yeah.
there's a couple of things I didn't say then, if this is where we're going, if that's okay. Because there's a couple of things that the Biden administration and other countries are being called upon to do, and I think we really need to talk about it now, because it's really relevant to kind of thinking about going forward. The first thing is the pandemic fund, which is supposed to have a $10.5 billion annual funding target, which is hugely under-resourced. But it's a question about if we're looking to get ourselves set up for the future, is to think about where it is that the US, but other countries as well, fit into that. The second is the pandemic accord, the pandemic treaty that is being negotiated, and the fact that last week, or 2 weeks ago at the General Assembly in the latest round, basically what came out was rhetorical. All the accountability mechanisms were thrown out. Basically, governments couldn't agree with anything that would have anything serious, and it's a really critical juncture as we think about moving forward. So I really want to put that on the table. It's the international health regulations, and what's happening with the international health regulations that everybody says need to be updated. But again, the question about whether there's government appetite for being able to think about how they need to be updated given current realities. And then how is it that we are going to, whether it's COVAX or other mechanisms, how we're going to ensure that, because there will be another pandemic. And the question is, how we make sure financially, basically, that we are ready, and systems-wide that we are ready. And the thing that I just want to say is this coming year is a make or break political window. This is the year. And so the question about, back to your very initial question, not initial, but one of the questions that you asked about kind of where are we right now and kind of where is it going, to me, this is the critical issue. We have pandemics around the corner, and we need to recognize that.
Bob, to your question around what can we do to sort of make our system more equitable, I do want to say that we know what's possible. I think more equitable outcomes is not a pipe dream. It's not impossible. And I think what we saw in the context of COVID, especially with early vaccination efforts, is that when you center equity as part of your policy priorities, when you line up, when you secure resources and then line them up behind those priorities, you actually can make a big difference. I think you can really meet people where they are. You can provide care or support or resources or vaccinations in this case in a way that really kind of disproves what a cynic might say is sort of structurally inevitable in the US. Shifting gears a little bit, looking forward in terms of where are the opportunities in our healthcare system. If you talk to any clinician today, or any researcher especially, they're like practically giddy when they talk about the impact of personalized medicine. And I think the question is, can we make our system more nimble and more adaptable to start to deliver the promise of some of these advancements that can come from personalized medicine in a very different way than the way that we deliver healthcare now? So can we be much more nimble? Can we have much more creative experiments that are much more close to the ground, that can actually meet people where they are in some of our hardest hit communities, among some of our highest need populations, because that's where you stand to gain the most from it. But if we know that if we leave things to the way they always work in our system, that is not what will get prioritized. It requires intentionality.
Intentionality. No, I couldn't agree more with what you said, Sujit, and also Sofia. This is a make or break year, and I think access, eliminating financial barriers to access, I think could go a long way. The Affordable Care Act helped, but we still have uninsured people in the United States that don't have access. So
Unlike Canada, yeah.
Yeah, now Canada has its own issues, but access is widespread, and so I think, but there's also equitable distribution of vaccine that's built into the system. So prioritization of vaccine rollout comes with which groups need it the most, which disadvantaged groups. Indigenous communities got vaccinated before the general population, and that was an effort to try to inject some equity into the process.
Sophia, you were making notes there. Did you want to say something else?
I am making notes. Okay, so all right, I'm caught, I'm busted. Okay, what I was thinking about was when you were talking about personalized medicine, I was thinking about the implication of how you move that to a population level.
Yeah.
And I think that that's really kind of the key issue is how do you do that? And so the question for me then becomes how do we think about equity in that context, right? It's really unclear.
And what do you mean when you say that it's a make or break year?
Basically, what happens right now is that we are in a year where there are these major pandemic accords. There are these major mechanisms that are in place. If we have what everybody's calling pandemic amnesia, and we forget the last 3.5 years that we've just lived through, and if we just don't prepare, then basically what we're going to end up is exactly where we were, but worse the next time it comes. This is really the time, because this is when all these things are being negotiated.
Either of you want to add?
There will be another pandemic, and we just don't know when.
That was the cheery news.
Hooray.
Let me turn this over to the audience for some questions. Anyone have a question out there? Yes.
You guys are talking a lot about like making changes to prioritize disadvantaged communities, but after the failures to actually effectively vaccinate and help those communities, why would they trust you now?
So the question is, why would disadvantaged communities trust in new efforts to achieve equity given what they experienced during the pandemic and the inequities that fell on them?
I think the question of whether people trust entities that have let them down in the past is A, an extremely tough one, and B, is one that it plagues us on any number of fronts right now. What I do know is that we've seen a number of examples that show that it's possible, that show that you can actually deliver better outcomes for disadvantaged communities. I think the vaccination efforts were actually a huge success on that front in terms of making vaccines available widely, freely, conveniently within 5 miles of people, setting up partnerships with community partnerships, making it available at free clinics and communities. I think there are templates that we've seen to be effective in that case. I think candidly the challenge is, taking the other side of my own argument, is something that was successful in sort of a once-in-a-lifetime pandemic crisis situation. How do we take lessons from that and make them replicable in a situation where we don't have effectively unlimited resources made available by Congress, where we don't have things on the front page of the newspaper every day, where we don't have every political leader willing to talk about it and willing to do initiatives on it? How do you create space for success and momentum and unconventional partnerships when you don't have that kind of air cover, for lack of a better word? That remains to be seen, but I think that is kind of where the rubber meets the road going forward.
Either of you?
I would just say one example I think that we've learned from this is that public health can't be paternalistic. It has to engage partnerships with community leaders. So I think the next time around, building trust has to be a partnership with members of communities that are affected, so that there's not just one message coming out that's this is what you have to do because we say so.
Yeah.
And public health has tended to retract to that side.
And I would also say that there have been so many good examples, just to really follow up on that, of communities leading, not following, that we really learned kind of in this period. And so it's really a question about how it is that those community leaders can help to grow and champion other community leaders to be able to do that. I actually feel more positive about that than a lot of the other negative things I said, to be honest.
Yeah, I mean, I think one great sort of effort that's underway is to shore up and replenish our public health workforce, but particularly focused on training and equipping people within the communities where they come from, so that you have more local embedded expertise and resources that are kind of available. Because it goes back to what we were saying earlier about, the most effective conversation is one that happens between two people that know each other and trust each other already.
Allison?
I'd like to follow up on that, the question about the training. What sorts of changes have there been in medical schools, public health schools? What sort of training should be provided that would enable various government officials to respond more effectively. And I was thinking also about the question of the unhoused, because in the United States we have so many people who are living in conditions of homelessness, and it was my understanding from people at the Inner City Law Center that it was difficult to persuade people to trust doctors they'd never met to, to give them a vaccination and then to find them again for the follow-up. So I was thinking of that as sort of a specific example of something that might be part of a training. I know some of you have done a lot of training.
Yeah, let me just quickly say one model that we use in public health now is called community-based participatory research, where investigators work in partnership with.
Dr. Stoner, would you just repeat?
Oh, I'm sorry.
The question,
the question is what. Thank you. What sort of training is needed to achieve this kind of equitable partnerships with communities? And community-based participatory research is a model where research ideas are generated in concert with community members and then put forward and operationalized. And so it's not the only model, but it's a model that develops information that then can be put into practice.
That was a great opportunity for me to talk about some of the work that we're doing right here at USC at Public Exchange with the team I'm honored to be a part of, where this question of training and equipping our healthcare workforce in the country, I think, is sort of an existential level challenge for us on the healthcare side. So what do we need to do? I think there are a number of things that are opportunities. Number one is we need to stop the flow of people leaving healthcare worker professions and clinician professions because they're burned out or overworked or unhappy. If you talk to most people who go into those professions, they did it because they want to take care of patients. So what can we do to free up more of their time, to give them better kinds of supports, both on the emotional and well-being side of the house, as well as just the process improvement, how they actually do their work. I will plug our own work here and say that there's a really exciting study underway right here at USC with Keck to do exactly that, which is to test interventions that are designed to prevent healthcare worker burnout, mitigate healthcare worker burnout, so that people can stay in the profession longer. Another opportunity I see is if you look at some of the disruptions that are coming to our labor workforce because of AI and technology, how can we create pathways for people whose jobs are about to be disrupted to transition over to a healthcare capacity where we're less likely to be in a technology disrupted position going forward? We have an aging population. We have a population that as much as 50% of us are at risk of diabetes. Going forward, we just need more people in this industry. And so can we think of bridges to bring people over? And then third, can we think of ways to train people faster? Can we get people sort of distributed workforce? I mentioned earlier that we don't have this cadre of people that are just like laying around with healthcare worker skills doing other jobs. What if we did, right? What if we actually did have at scale, everybody having base levels of healthcare training that they were able to use in an emergency or in a crisis, things like that. I'd love to see stuff like that get underway.
Can I just add, I'm totally with you. Just two things. We had, as in terms of public health education, there were more young people applying for public health training from 2021 and this 2022, 2023 than ever in the history of public health nationally, right? So that's been like hugely important. And then the question is, how much do you grow kind of your public health training? So here at USC, we have a robust Masters of Public Health program. There was a really honest debate about how big should we let our class get, right? And like, what does that actually mean in terms of actually being able to think about how to do that? So I think one of the things is basically to be able to think about how do we harness the good energy of young people who realize that this is something big and that they realize they want to do something with this in terms of their lives. The second thing in terms of how is it that we think about what kind of training, like I 100% agree with all that, but I also think, and it goes, I think, Alison, to the other part of your question, is how is it that we train people in public health to really be focused on the social determinants of health, so that they're actually recognizing how housing is relevant, how education is relevant, how all of those things are relevant, how structural racism is relevant in terms of being able to think about how is it that those things become part of a public health person's responsibility, not just some idea out there.
As the non-expert on this panel, I'm going to add one thing that goes to your question about homelessness. My wife is very involved with the Downtown Women's Center, which deals with thousands of women on Skid Row who are homeless. They managed to vaccinate an extraordinary number of people. I mean, doctors came there, not because these folks knew the doctors, but because they trusted the Downtown Women's Center because it's where they could go to get food, it's where they could go to have a little bit of a social life with somebody, it's where they could go for employment counseling. So I think all of this says that you've got to integrate, and what do I know? You've got to integrate the healthcare delivery system with the agencies and people who are actually trusted by the folks who are suffering the greatest inequities in the system. Now, and by the way, I'm repeating the questions because there's not a mic out there, not to be impolite. Yeah.
I just wanted to add to that in terms of Downtown Women's Downtown Women's Center, that they actually instilled a program of hiring people to help them have like temporary jobs of being that community health worker, so to speak, in a very short period of time, amassed a large number of temporary sort of people to facilitate the bridge between the person needing the healthcare and the healthcare workers.
That's a very interesting comment on the Downtown Women's Center here in Los Angeles, hiring people to be intermediaries to go out and help folks get the health care they need, the vaccination they need, and it was an outreach program that worked.
And it was very little training just to amass this group of.
Yeah, it wasn't a lot of training. It wasn't like, they didn't get a master's, but they mastered enough that they could go out and they could have a big impact on the community.
And just to connect with people so that they would be trusted.
Right. Yeah, all the way up there, and then I'll come back here.
I live in San Francisco. One of the things I find very incongruous is during COVID, which was treated as kind of the second coming of the Black Plague, everything was locked down. Twice as many people died of fentanyl overdoses than did from COVID, and that continues. I think it was the same in LA County, and yet all we're hearing about is COVID and vaccination, how important that is. People are literally dying in the streets every day. And
So the question is, the death toll from fentanyl in places like San Francisco was higher, maybe twice as high as the death toll during COVID. And I suppose the implication of the question is, why aren't we focusing more on that?
Yeah, I think we should. We absolutely should. It's a crisis. It's no longer substance abuse. It's substance poisoning. So people are dying of preventable overdose. And we're, as a society, we haven't embraced that. So on public health, we talk about harm reduction. So we, in Canada now, there's safe use sites, not just safe injection sites, but safe supply sites where you can go and actually get, drugs that are not, are not laced with fentanyl. And that's controversial even in Canada. But it's a movement that really needs to be looked at, and we need better evidence to support that. But I think society is really under-recognizing the impact that this is having on our young people. We have actually seen a decrease in the longevity for the first time in probably a generation or two, life expectancy.
It's a good example, I think, also something you mentioned earlier, Brad, which is around public health needing to be, driven by data, driven by science, and that's true. But also, oftentimes, public health interventions are exercises in political communication, right? Because ultimately, you're trying to affect people's behavior, you're trying to get buy-in, and that requires political communication, which requires you to sort of work in the space of politics in that way.
Yeah.
And I think to your point about sort of the disparity between the attention and what's happening is about priorities and about who's speaking and whether it affects them and whether they see it as a proximate challenge to them when they have a microphone or they have a platform. And I think it's a good example of issues that affect marginalized communities rarely make it to the front page or to the top priority list of officials. And I think it's a great example.
I also think, by the way, had San Francisco not, had LA not, had California not reacted to COVID the way it did, you might have had much higher death rates. You might not have been talking about fentanyl casualties being twice as high as COVID casualties. They could have equaled each other because this was an incredibly infectious disease.
Yeah. No. Yes, and yes. But the only thing that I would add is I want to come back to the harm reduction perspective, which is also this question about what does it take to decrease the stigma that is around the people who use drugs and their ability to access the drugs that they need, right? And how do we think about doing that? So that is a public health messaging issue, but it is also about how do we change kind of the perspective of how we understand what is public health, right? And so I don't disagree. I didn't actually know those numbers, frankly, until you just said that. But I think in general right now, I think that what I feel positive about, I mean, I've only been back in California now about 10 years, is that I do think that there's a lot of conversation here now about harm reduction and about actually thinking about how do we mitigate and how do we deal with drug overdose in such a way that we can actually support communities.
Okay, I'm going to go one more over here. Sure, go ahead.
Yeah, I just wanted us to go back to that issue of the polarization in the country, because obviously, like, equal rights is sort of a crazy polarization right now, and then also gender-affirming care, demonization of public health. If you go into central Illinois, you see all these copies of that book against Fauci. People are, seeing him as the devil or something. I think that's really tricky for the future, that we are getting that polarized on health. And for instance, there was just an article, I think it was today or yesterday in the Washington Post, saying that the red states on everything, I mean, it's like wearing seatbelts or helmet laws or you name it, they're way behind. But then when it comes to things like infectious diseases, pandemics, we have half the country that just will not get with the program at all. We have this problem in California. The CHIS data, the California Health Interview Survey, just said that a third of Californians will not get a booster. 11% in the future will not wear a mask, no matter what. So that's just here in California. But I just wanted to hear from the panel a little bit more on this specter that we have. I mean, I don't see it being easily reversed. Friends of mine are fighting those battles on the reproductive rights front, and it's going in a worse direction some places.
So the specter of polarization, people even in California, a third of them, you say, will not get a booster.
Will not get a booster.
Right.
11% will use a mask. That's here.
A percentage say they'll never mask again, no matter what. You go into central Illinois and people are selling books about how Dr. Fauci is the devil. I mean, these do seem like pretty insurmountable obstacles. So how do we surmount them?
This is Paula Tavro from, not to be polarized, the public health school of Boston.
Welcome.
I think it's a great question. I don't know if there's a good answer.
I go back to it's the greater public good versus individual autonomy, and that's really what this is about. People have clear ideas about what public health should and shouldn't be doing, and I think restoring trust, I mean, Sujit, you talked about this, and Sofia, the idea of trust in our public health system has really been challenged, and I think it'll take time to rebuild. So
it's not an easy answer. Okay, I promise I'd come back to you. Last question.
Thank you, and thanks for this really thoughtful presentation. I'm Lee Turner. I'm UC Irvine, but a graduate of USC.
Louder, please. Louder.
Sure. Okay. So my question is, about 10 days ago, the Washington Post ran an investigative piece, and it was about attacks on misinformation researchers, on health misinformation researchers in particular. And those attacks came from some of the different players, but Representative Jim Jordan was mentioned as one of the key figures and some of the politicians. So my question is, so in other words, academic institutions we're part of this politicized environment we've just been discussing. This seems to have had the effect of health information researchers losing access to funding, NIH losing about shelving about $150 million worth of funding, some researchers deciding not to continue with their research programs, others deciding to leave public institutions for private institutions so it'll be better shielded. And so I guess what I'm asking is, what are your thoughts in terms of what academic institutions can do to kind of preserve healthy academic scholarship, looking at health-related misinformation related to COVID and beyond, looking at conspiracies and myths, and kind of addressing all of the issues that are connected to COVID and kind of misconceptions, public misunderstandings. Any thoughts about how academic institutions can try and ensure that this kind of research continues and doesn't just kind of wither away in the face of what seem to be quite significant assaults right now.
So given the attacks on those who expose misinformation about health, what can academic institutions do to push back and to preserve the integrity of the information that gets to the public and make sure that people know real facts, not alternative facts?
I don't have an answer, clearly, but I have a couple of thoughts of things that I think are really, that I kind of want to put out there. So one thing is that I think one of the issues for faculty is this question in terms of being able to think about what's respected as scholarship in terms of promotion. And so for junior faculty, it's really a question for them in terms of how is it that the work that they're doing in this area can be respected, and that's something that universities can do by touting that and not hiding that. So I think that that's kind of one, I think, really important area. I also think that there's a safety issue, and I think there's a physical safety issue. I mean, I have friends that are faculty in some pretty extreme red states who have to worry for their physical safety. That's something that really needs to be addressed. So I'll just put those pieces out.
Yeah, I would just quickly add that I don't have great answers, but I do think being clear-eyed about the stakes of this kind of research and this kind of work is important for those who are doing it. So on both sides. Number one, I think that the ordinary, and I'm painting with a broad brush here, so I apologize. The ordinary sort of like rhythm and incentives of academic research is to come up with a question that's novel and interesting, gather evidence, study it, and then scream as loud as you can about the findings so that hopefully somebody listens, reads it, builds on it, informs policy, whatever. That last piece can be a little bit dangerous if you're thinking about combating misinformation. And so we need to think carefully about, okay, what am I going to do with the learnings here, number one. Number two, from just like an OPSEC, operational security standpoint, like how am I going to protect myself in the form of doing this work? How is the institution I'm working with going to protect me, and if we're going to endeavor to do this kind of work? And I think you need to be really intentional about that kind of work. On the other side of the coin, it is so vital. It is such important work. It is like, you know, national security level important, and I think it ought to be treated with national security level rigor and seriousness.
I don't have a whole lot to add, but other than this is not a new phenomenon, it's just it's been ramped up. The stakes are higher, but people working in the reproductive health space, as I do, have been subject to this for a long time. So there is some concern about personal safety, and it's. I think we just have to be on the side of what's right and do the, you know, proceed with. But
in some states, by the way, I think you're going to see researchers and scholars leaving public universities.
Sure.
Because they think they can't do their work there.
If I can just add to that, which is that you also see we've had more students who want to come here to be trained because they don't want to be in states where abortion is no longer possible, right? So it's basically changing kind of the face of student, I mean, for exactly the way you're saying.
Yeah.
Well, and
also the
lawyers too.
Lawyers and just
Employers, sorry.
Employers.
Yeah.
The curriculums are being monitored as well, so you can't teach critical race theory in certain states.
You can't read Anne Frank's diary in some of these states. It's ridiculous. And that is an opinion that I'm express. So I want to thank our panelists, not just for your insights and your candor about an issue that I fear may get neglected over time as we get more complacent, but for your contributions and for the difference that you've made that has almost certainly, in each of your cases, saved lives. I want to thank all of you in our audience and apologize to you for not getting to your question. This discussion will soon be available on YouTube and Facebook, and our Bully Pulpit podcast, turn all our events into a Bully Pulpit podcast, will be online in the next few days. Finally, once again, Alison, thank you. This wouldn't have happened without you.